Dagan Wells from Oxford, England. Welcome.
Thank you very much.
It's a very big pleasure having you here today.
The pleasure's mine. I think I have this. Thank you. Well, thank you very much for the invitation to be here. It's such a pleasure to be back in Helsinki after a few years. And great pleasure to celebrate Dextra, which of course has been a real driving force in IVF in Finland, particularly in the area of genetics, which is my area of interest. So Ira asked if I would speak a little bit about the genetics that we're doing in relation to IVF and where that might be going. So I guess just to give a bit of an introduction, we can think about the inheritance of genetic conditions. And we might think that this doesn't happen that often. Most of us here probably don't have a genetic condition. Maybe we don't know too many people who have. But the reality is that in the population at large, genetic conditions are relatively common. There are more than 6,000 individual inherited conditions. And if you actually sequence your own genome, on average, you'll find that you have about 15 mutant genes that could be quite bad for your health, but you're probably okay, because we have 2 copies of each gene, one that comes from mother, one that comes from father. And most of these conditions are what we call recessive. You need to have 2 defective copies of that gene to have the condition. So we escape these despite carrying these mutations. So most people who have a mutation are not aware of it. They probably don't have any affected relatives. They probably don't have the disease themselves. And yet, when we look in the population at large, about 1 birth in every 300 actually has an inherited condition. And if you look at things like neonatal deaths, the deaths of newborn babies, there's a disproportionate impact of these inherited conditions. About 1 death out of every 5 has some kind of genetic link to why that baby didn't survive. Now, when that happens to a couple, of course, it's devastating. But the majority of them, 80% of couples, never knew they were carriers of this particular condition. Now, sometimes when I tell people that, they think, well, how could they not know? Surely, maybe Uncle John was a little bit strange, or maybe there was a cousin that had something not quite right about them. But actually, as I say, these recessive conditions can stay hidden for a long time. If we look at this family here, this is how we usually draw genetic pedigrees. The ones that are divided in half, those are carriers. So they don't have the disease, but they've got 1 bad copy of the gene. So you can see mum, she's the circle, and dad, he's the square, are both carriers. But they don't have the disease because it's recessive. They've had a son, that's the square at the bottom there, he's completely unaffected, so that's lucky. A daughter who's got 1 of the bad copies from 1 of the 2 parents and a good copy from the other one. And so she, like her parents, is a carrier. But unfortunately, there's a boy on the right who got the bad copy from each parent, so he has the condition. Now, how long do you think it will be before another affected person turns up in this family? Well, obviously it depends how common the mutation is, the disease is in the population. If I was in the UK, we could say something like, okay, let's have these assumptions. We assume that each generation, maybe the family has 2 or 3 children, pretty typical. And let's make it as likely as possible that they're going to have another affected child. So if I'm in the UK, the most common inherited condition is cystic fibrosis. About 1 in 25 people carries a mutation. So anyone who marries into the family has a 1 in 25 chance of carrying a mutation in the same gene. So how long do you think, anyone want to have a guess, how long do you think it would be? How many generations until someone else is affected? 1, 2, 3? What do you think? Well, it turns out that on average, you'd have to get all the way down to here before you would find another couple who are at risk of having an affected child. And even they might not have an affected child. Maybe they're lucky and their children are all unaffected. So it could go on even longer. So you ask the question, do we know that we have a risk of having an affected child? Well, does this person down at the bottom here, who inherited her mutation all the way up the family from here, does she know that she carries that mutation and has a risk? When the last person affected in the family was her great-great-great-great-great-granduncle. So how many of you know the genetic health of your great-great-great? Obviously none of us do. So you can see even the most common conditions soon get forgotten about over time. This is probably the distance of about 175 years. So because of this, the question is, would it be better to know if we have a risk? If a couple does know that they're a carrier of a mutation and they find out that their partner is also, then they can have appropriate counselling about what their reproductive options are. They could have prenatal testing, pre-implantation testing, as we'll discuss in a moment. They might choose to remain childless or adopt or have a donor gamete. At least they can make an informed reproductive choice. Now, it's now possible with the advances in genetics that we can test hundreds of genes in one go simultaneously and at relatively low cost. 10 years ago, it would have cost the same to test one gene. Now we can test hundreds for the same cost. This is sometimes called expanded carrier screening. And the reason I particularly mention it is that we're seeing it used more and more often in the context of fertility treatments. So this is something you might want to do whether you're infertile or not, just when you're planning to start a family, just to know, is there a risk? We find that about 95% of couples find, yes, they have mutations, but not in the same gene as their partner, so there's no risk. But it's just for those few percent where it can make a life-changing difference to know before the birth of an affected child that the risk is there. So people are doing this, fertile or not, but particularly you don't get a more planned pregnancy than an IVF pregnancy, and so that's where we're seeing it done a lot. We're also seeing it used very widely now in gamete donor programs. When a sperm donor is being used or an egg donor, patients in some countries have quite a lot of choice about which donor they use. And it makes a lot of sense not to present them with a donor who has a mutation in the same gene that they have. That's easily avoided, and so we do an awful lot of that now, and that's really been beneficial. Of course, if a couple finds that they do both carry a mutation in the same gene, there are lots of options, and if they're having IVF, one of them is pre-implantation genetic testing. So essentially, this involves testing cells from the embryo itself and seeing whether that embryo is affected by an inherited condition. If it is, you don't transfer it. If it isn't, then that's one of the embryos that could be chosen for transfer. Essentially, it begins just like any other IVF cycle with ovarian stimulation to hopefully produce several eggs. Those would then be fertilized with the partner's sperm in the hope of producing several embryos, and they would then be biopsied, and here we see an embryo at the blastocyst stage, so this is about 5 days old. It's still surrounded by the zona pellucida, the membrane that covers the egg. But this embryo is halfway through the process that we call hatching. It's emerging from this zona pellucida. If we looked at it again in a few hours, all you'd see is the embryo floating freely as a nice ball and this empty shell left behind. But this is a very nice time at which you can take a few cells, and that's what you can see happening here. You can see it's quite an invasive procedure. They tug on the cells, they shoot them with a laser to break off, usually about 5 cells. The embryo, though, tolerates this extremely well, and those cells provide us with the genetic information to test whether the embryo has a particular mutation. So we hope to find some embryos to be unaffected, and those can then be transferred to the uterus to hopefully give us an unaffected pregnancy and a healthy birth. So one of the main reasons for using this rather than traditional methods like prenatal testing is that it avoids the issue of pregnancy termination. You're only going to begin a pregnancy with an embryo you've already shown to be unaffected. In contrast, with prenatal testing, you wait till the pregnancy is established, test it, and then if it's affected, you have to consider, make the difficult decision, whether to go through with the pregnancy and have the affected child or to terminate the pregnancy. So why do patients go for PGT? Well, many of them are opposed to pregnancy termination, and that could be because of their own personal ethics, might be religious reasons. It might be because they have tried to get pregnant normally and they've had 1 or 2 or 3 affected pregnancies, terminations, and they just don't feel that they can do that anymore. Interestingly, from an IVF perspective, many of the PGT patients are perfectly fertile. They don't need IVF to conceive, but they do need IVF so that we can access their embryos before pregnancy. So they're an interesting group. Of course, we also get patients who are kind of doubly unlucky. They're unlucky enough to need IVF to conceive, and they're also unlucky enough to have an inherited condition going through their family. And of course, for them, it doesn't make sense to struggle, sometimes for years, with IVF, to finally achieve a pregnancy and then to find out it's affected and maybe have to consider a termination. So for them, of course, it makes very good sense to do testing at this stage. So this kind of testing, where we're testing one disease gene, monogenic disease, it's increasingly popular. We're seeing a lot of cases. The accuracy is very good. It's usually in excess of 98%. So it gives, you can't say it gives a guarantee of an unaffected pregnancy, but it certainly swings the odds greatly in favor that the pregnancy will not be affected. The biopsy of the embryos does not seem to be detrimental, but it is a skilled procedure, so it needs to be carried out by people who know what they're doing, and it's definitely an effective strategy. Very important to work with a good IVF lab that's well experienced in this, but also very much a good genetics lab with good validation and accreditation. So, in a way, that kind of genetic testing of embryos is a little bit niche. There's not a huge population of patients that need it, although we do see more cases each year. The genetic testing of the embryos that's most widely done is what's called pre-implantation genetic testing for aneuploidy, or PGTA. And this is not so much about looking for inherited diseases that some families have and some families don't have. It's looking for genetic abnormalities which actually we can all have in our embryos and which stop them forming a successful pregnancy. If we just think about IVF, we've had IVF with us now for more than 40 years. And we have, of course, it's revolutionized infertility treatment and given rise to an estimated more than 12 million births around the world. That's between 1% and 5% of all births in industrialized countries. But underneath these big headlines, we have to admit that despite having this with us for more than 40 years, the process is still remarkably inefficient. And here's just an example of that. This is UK data from the Human Fertilization and Embryology Authority, showing you the chance of an embryo actually implanting after transfer. And you can see it's getting better with each year, so that's really good. A lot of hard work has gone into improving those rates over the years, but still we're at a point back in 2018, and it's not much better now, that for the younger patients, the best prognosis patients, still only about a third of the embryos transferred actually produce a baby. And part of the reason for this is that the way we choose embryos is not a very effective way of knowing which ones have the best chance of producing a baby. It's done based on their appearance down the microscope, their morphology. So we need really better methods for being able to identify which embryos are viable and can make a baby and which ones cannot. So the question has been, could genetic tests do this for us? If we use something like pre-implantation genetic testing and took a few cells from the embryo, can we learn which embryos are viable and which are not? And this effort has mostly focused on the chromosomes. Every cell in your body, pretty much, has a full set of your DNA. And that DNA contains all the genes, all the chemical instructions that build your bodies and keep those cells alive. And those genes are stored on the chromosomes. They're rod-like structures like this, as you see. We have 22 different pairs. Again, one would come from mum and one would come from dad in each case. And we also have the sex chromosomes, 2 X's if you're a girl, an X and a Y if you're a boy. That's what we would like to see. But often, when we look at embryos, we don't see that. We see maybe a chromosome too many, like in this case. This is a Down syndrome conception with 3 copies of chromosome number 21. Or we see too few chromosomes. Both are possibilities. The main thing to know is that these abnormalities, when you hear that someone's pregnant, the chances are that their pregnancy will be chromosomally normal. But when we look in embryos at this much earlier stage, we find very high levels of chromosome abnormality. And it goes up dramatically with advancing age. As you can see, this is the incidence of chromosome abnormality in embryos at the blastocyst stage. These are 5-day-old embryos, so these are what we consider good embryos. They've survived all the way to the end of pre-implantation development. I guess 2 things to note. It's pretty common, even in younger ages. You've got about 15 to 20% of embryos being chromosomally abnormal in young patients, but it certainly goes up with age. By the time a patient is 36, about 1/3 of her embryos will be chromosomally abnormal. And after that point, the chromosome abnormality rate increases at a rather frightening 0.7% per month. So you can see that by the time a patient is, say, 42, you've got more than 3/4 of the embryos being chromosomally abnormal. Now, why do we care? What does that really mean? Well, these chromosome abnormalities are almost always lethal to the embryo. So as the proportion of embryos that are abnormal goes up, the chance that the embryo you choose to transfer to the patient being abnormal is also going up. And that means the chances of it making a pregnancy is going down. The abnormal embryos do not usually make pregnancies. And so the implantation rate, the chance that the embryo makes a pregnancy, goes down with age. And as a scientist, when you see a line like this and a line like this, almost a mirror image of each other, then it's a pretty good guess that this is cause and effect. The reason IVF gets harder with advancing age, the reason why embryos from older patients implant less often than those from younger patients is because they have a greater chance of being chromosomally abnormal. So it explains many, if not most, cases when an embryo is transferred but doesn't implant. It's been known for decades that chromosome abnormalities are the main cause of miscarriage. I'm not particularly talking about recurrent miscarriage here, but just the sporadic miscarriages that can occur to anybody. Probably at least 2/3 of those are related to chromosome abnormalities. And of course, they cause aneuploid syndromes, things like Down syndrome, Edwards syndrome, Patau syndrome. So the concept has been, if we have a lot of chromosome abnormalities in our embryos, which we do, and if those abnormalities are lethal, wouldn't it make sense to only transfer the embryos that have the right number of chromosomes? So if we have maybe 4 nice embryos here, maybe 2 are chromosomally abnormal and 2 are not, rather than transferring one of these based on their appearance, which tells you almost nothing about whether their chromosomes are normal or not, why not do a test which allows you to specifically transfer one which is chromosomally normal? It's not going to guarantee that you get a baby, but it will eliminate what is the single biggest factor in an IVF embryo not making a successful pregnancy. Does it really work? It's been quite controversial over the years, not because the idea is wrong. It really is true that we have high levels of abnormality, and it really is true that that is usually lethal. But the technology has not always been really accurate and robust enough to deliver on this concept. But I think that has all changed in the last couple of years. I would like to show you this study. This is using the methodology we use in our lab. It's an interesting study design where embryos were biopsied, just as I showed you, at the blastocyst stage. Those few cells were taken away and they were just put in the freezer. They were not tested. The embryos were then transferred just as though it had been any other IVF cycle based on their appearance. No genetic tests done. They then waited to see whether the embryos implanted, miscarried, produced a baby. And after that, they went back, took the sample out of the freezer and tested it, using the method that we normally use for testing embryos, the PGTA method. The idea of this is to let you know what the result would have told you. So they found that just over 300 embryos would have received a normal diagnosis had the test been done earlier. 65% of those didn't just produce a pregnancy, they actually produced a baby. So that's very nice. It says when you have an embryo which has a normal diagnosis, about 2/3 are going to produce a baby, and that's regardless of the age of the patient. But the really interesting thing is something that you can never get from a randomized controlled trial, because in a randomized controlled trial, you have some embryos that are tested, and you only transfer the normal ones, and you have some embryos that are not tested, and you don't know if they're normal or not. But this allows you to ask the question, what happens if you transfer an abnormal embryo? In other words, how useful is it to know that an embryo is abnormal? So it turned out that over 100 embryos transferred would have been diagnosed abnormal. Not a single one of those made a baby. Most of them didn't implant, a few of them miscarried. So this tells us that with this particular test, we can test an embryo, and if it gets an abnormal diagnosis, it's almost 100% certain that it will not produce a baby. There is no other embryo assessment method that exists that has that level of certainty associated with it. So I think that's a major advance. So just to summarize on that, what is the benefit of chromosome testing? Well, it should increase the chance that the embryo chosen for transfer is viable. That should give you a faster time to getting pregnant if you're a patient. And that's something that's often overlooked in IVF. People say, oh, don't bother with these tests. Just transfer one embryo, freeze the others. And if the patient doesn't get pregnant, thaw out another embryo, transfer it. If she doesn't get pregnant, let's just do an example of that. So there's a typo on this, not 8 embryos, but 4. You have a 40-year-old patient, 4 embryos, and you think, I don't want to do PGTA, I'm going to transfer one at a time. So you transfer the first embryo and you freeze the others. What is the most likely outcome for a single embryo transfer in a 40-year-old woman? The most likely outcome is that you get no pregnancy. So that would not be surprising to you to see this. The patient will be disappointed, of course, but she has 3 more in the bank, so it's not the end of the road. You let a little time pass, you get the patient ready again, you transfer another embryo, and you get no pregnancy. Again, completely in line with expectation. This is typical. So, okay, that's really disappointing now because the patient is aware that you're transferring the embryos that look best first. And so with each transfer, it gets a little bit more. Anyway, she carries on and she has another transfer and you get a pregnancy. So she's delighted, you're really happy for her. But about a quarter of all pregnancies that you achieve with IVF in a 40-year-old will not go to term. And so it wouldn't be surprising to you if she came back to you maybe a month or 2 later, having lost the pregnancy. Of course, that's devastating. For a patient who desperately wants to be pregnant and has struggled to become pregnant, to then lose the pregnancy is particularly hard. And perhaps you even maybe need to do surgical intervention to clear up the miscarriage. Time passes. Some patients will give up at this point. They know that the worst quality embryo is the one that's left behind now, so it has the least chance of the 4 that they had, that they may feel that they've been on this roller coaster for long enough and may not come back for the last embryo. But say that your patient is really determined and they come back and they have the transfer and they don't get pregnant. Now, this is not an extreme example that I've given you. If you're lucky enough to have 4 embryos from a 40-year-old, which often you won't have, then this is not an unlikely scenario. This patient has had 4 unsuccessful transfers. Let's not forget, those are medical procedures that don't just have a financial cost, they have a big emotional cost for the patient as well, and they've all been unsuccessful. She's had a miscarriage to deal with as well, and this has all taken a lot of time. She might have been 40 at the beginning of this, she might be heading for 42 by now. All that time, the chances of her having success with her own eggs has been going like this. Now, if you'd done PGTA at the very beginning, you may well have found that all of these embryos were abnormal. That would have been really disappointing, but it would have saved the patient from 4 transfers, 1 miscarriage, and would have allowed her to decide, age 40, do I try again with my own eggs while I still have some reproductive potential, or do I give up on IVF, or do I go to egg donation? Better to make that decision age 40, where there is still a decision to be made, than 42. So fast time to pregnancy, especially important in the older patients. Avoid unnecessary embryo transfers, as we've discussed. Avoid cryopreservation of non-viable embryos. I mean, there's more than a million embryos frozen around the world. I can guarantee to you that at least a quarter, and maybe closer to a half, are chromosomally abnormal and will never give the patient a pregnancy. So why are the patients paying for their continued storage every year? And worryingly, there'll be some patients who think they have a guarantee of their future fertility because they've frozen some embryos. But if those embryos happen to be abnormal, then there's no guarantee, and they should think about cycling again as soon as possible. So that's really important. Obviously, reducing miscarriage rate. Most miscarriages are caused by chromosome abnormality. You won't be transferring those embryos, so you shouldn't get those miscarriages. You still will get some miscarriages which are not related to chromosomes, of course. Reduce the risk of Down syndrome. It's been shown, using our PGTA method, we've done follow-up of more than 1,000 pregnancies, and using prenatal testing, non-invasive prenatal testing. Out of those, I think it's about 1,100, 4 of them came back as being high risk of chromosome abnormality. Were those mistakes that we made? No, because when they actually then did the follow-up testing, they were false positives for the non-invasive prenatal testing. So it actually turned out that 0 pregnancies actually had Down syndrome or any other chromosome problems after this kind of PGT. So should all patients be offered the testing? Well, I think it should at least be part of the discussion now. But it's really important that the methodology has been well validated. PGTA is an umbrella term, and some things called PGTA are not half as accurate or validated as other things. And so you really need to ask whoever is providing PGTA some difficult questions. Have you proven that the embryos you say are aneuploid don't make babies? Have you biopsied the same embryo 2 times and confirmed that you get the same result? These are the sort of technical but important questions that have to be asked. You do need to manage patient expectations. This does not make the embryos any better than they were before. If they were all abnormal to begin with, they're still all abnormal after PGT. It's an embryo selection tool to optimize IVF, but that's where it ends. I just have 2 more slides, which I'll just quickly go through, just to mention where the field is going. It's been a very interesting ride being involved in pre-implantation genetics. There's never been time to get bored, and it looks like that continues. One question is, we can get the genetic material from the embryo. How much do we want to do with it? Do we want to sequence the whole genome rather than just look at an individual gene? In the past, it was very easy when people posed this sort of question. I could just say, well, it's an interesting philosophical idea, but whole genome sequencing costs far too much and technically is impossible from a single or a few cells. But the truth is that that's not really the case anymore. When we sequenced the first human genome, it cost $3 billion and took 10 years. We can sequence a genome now in a single day and for under $1,000. That's a 3 million-fold reduction in cost over about the last 15 to 20 years. So it really is now potentially possible from an economic perspective to test the entire genome of an embryo. But this opens all sorts of ethical questions. You can't consent the embryo and yet you're testing all of its genetic information. Who's going to have custody of that information? Who will have access to it? You'll learn things not just about the development of the embryo and whether it can make a baby, but also whether it will have early onset Alzheimer's. How will this ever be conveyed to the embryo once it's born and grows up? You'll find out that it has mutations that might actually be relevant for the parents too, because that's where the embryo got them from. So it's a difficult area ethically. And so we need to start deciding how this will be regulated, how data will be stored, and what we want to do with it. The other question is, I've talked a lot about testing and finding out if an embryo has a defect or not. This means the embryo is then discarded if it has a defect. But would it be desirable not to discard the embryo, but to correct the defect? If someone needs a kidney transplant, you give them a new kidney. Could you give an embryo a new gene? So this is an interesting possibility. This is some work we're involved in with Kathy Nayakan, who's now in Cambridge, just doing some genome editing of human embryos that were not going to be transferred. So these are ones donated for research. It would mean that no embryos would need to be discarded. You could argue that that's ethically preferable to PGT, which involves discard of embryos. But of course, it has been science fiction until the advent of things like CRISPR, genome editing. There have been huge advances here, meaning that we can now potentially alter the sequence of individual genes, potentially removing mutations. But again, it's an area which, of course, is fraught with ethical questions. Should we tamper with the human genome? Is it safe to do so? Might we accidentally cause damage while trying to do something good? The data we have at the moment actually suggests, yes, there's a very high risk that that might happen. But it's an evolving story, and you can imagine that if we have this talk again together in 10 years' time, it may be something that's quite possible. So again, how do we regulate this? What do we really want as a society? And what is beyond what we would like? Thank you very much for listening. It's been a real pleasure.
Lovely. Thank you so much, Dagan.
It's a pleasure.
Excellent.